visual processing. But as noted earlier, those optic tract axons also go other places, particularly into the midbrain, associated with the pretectal nuclei, into the hypothalamus, to the suprachiasmatic nucleus, and also into the area of the superior colliculus. Finally, note, as you can see here, that the optic radiations, the visual radiations, represent axons of cell bodies in the lateral geniculate body that sweep back posteriorly through the parietal lobe on a corresponding side and synapse in primary visual calcarine or striate cortex on the medial aspect of a corresponding hemisphere. So now, let's be a little more specific about other sites and the significance of where other optic nerve or tract axons synapse. And this is a wiring diagram of the neural mechanisms involved in the pupillary light reflex pathway. Whereas we said some of the optic nerve and optic tract axons, instead of going to the lateral geniculate body, synapse on pretectal nuclei in the area of the midbrain in front of the superior colliculi. But note what the job of those pretectal nuclei are. They basically send axons that synapse on both nuclei of Edinger-Westphal. So by activating the Edinger-Westphal nuclei bilaterally, in response to a unilateral visual stimulus, there is bilateral pupillary constriction. So summarizing, we can say faithfully that the afferent limb of the pupillary light reflex are the axons of the optic nerve and the optic tract, which project to the pretectal nuclei. And then the pretectal nucleus projects bilaterally to the nuclei of Edinger-Westphal, basically adjacent to the oculomotor complex. And basically when that happens, you get bilateral pupillary constriction, meiosis, in response to a unilateral stimulus. So now, that's the point, is that when you shine light in one eye, activating only one optic nerve, you not only get a constriction of the pupil on the side of the light stimulus, a direct response, but you also, under normal circumstances, would have a concentric response because the contralateral or the unstimulated pupil will constrict to the same degree. And here's the point. This is a diagnostic or differentiating feature. Because this reflex does not include any visual structure in the thalamus, visual radiations, or cortex, a patient who suffered from a cortical lesion or a lesion past the lateral geniculate body will basically have an intact pupillary light reflex bilaterally. So now, other associated pupillary anomalies, one of which is kind of an incomplete lesion that basically results in a loss of the components of the light reflex, but the accommodation convergence reaction is intact. This is commonly seen in patients that develop late-stage neurosyphilis, tabies dorsalis. It's also seen in patients that develop diabetes, where basically the patient's eyes will accommodate normally in response to a nearly approaching stimulus, so you'll get pupillary constriction under those conditions, but the pupils will not respond to a light stimulus presented to either side. So a third kind of pupillary anomaly is known as a relative afferent or Marcus gun pupil, and this basically is tested by utilizing the swinging flashlight test. For example, if you shine a light in a pupil that suffered from a complete optic nerve lesion, neither pupil will constrict in response to light. When you swing the flashlight over to the normal eye, both pupils will constrict fully. But then when you swing the light back immediately to the affected eye, there is a sort of a paradoxical dilation of both pupils because the stimulus carried through the optic nerves is somewhat weaker. Again, a Marcus gun pupil is a feature seen in patients with multiple sclerosis because remember again that all of the axons of the optic nerve are myelinated by oligodendrocytes that are affected unilaterally or bilaterally in patients with MS. Let's use this diagram and subsequent ones to kind of devise a lesion strategy based on lesion sites that occur either in front of the optic chiasm to an optic nerve, a lesion at the chiasm, and a lesion posterior to the chiasm. So we're going to derive different signs and symptoms basically to help you localize a lesion to one of these three areas. First off, let's talk about the characteristics of lesions that occur at any of these sites. So now typically when you have a lesion to a visual structure, these are expressed as shading representing a visual loss in either a nasal or a temporal hemifield of one or both eyes. And they're indicated as shown here by these circles with partial shaded areas on the left side of this figure. So now, let's describe the characteristics of all lesions that occur in front of the chiasm. As we indicated over on the left side, these visual field deficits are described as being monocular and ipsilateral. What does that mean? If they are monocular, what that means is you're going to only have visual field deficits or shading in one circle. And you can see this is certainly characteristic of the visual field deficits illustrated at lesion number 1 and lesion number 2. And not only do you get just shading limited to one circle, the circle or the visual fields where the shading occurs is on the same side ipsilateral to the lesion. So let's see how this works. In our example here, first off, we illustrate what virtually is a complete lesion. Let's say a patient that has severe forms of multiple sclerosis or maybe an occlusion of the central artery of the retina at number 1. In this case, no information, regardless of which nasal or temporal hemifield on the left is being perceived. So the patient is described as having a complete anopsia, a loss of vision of the left eye. Again, left optic nerve lesion, a monocular and ipsilateral left side anopsia. So now, if the lesion occurs at number 2, which is in the optic nerve fibers just in front of the chiasm that are passing on the outside or lateral aspect of the optic nerve, this patient basically has a more restricted lesion. Recall that the fibers on the outside of the optic nerve are not crossing in the optic chiasm, and therefore, as indicated by the solid line, are coming from, in this case, the left temporal retina, which represents information coming from the left nasal visual hemifield. So compression of just the fibers on the outside of the optic nerve at number 2 would again result in a visual field deficit that is monocular and ipsilateral and would result in a left ipsilateral nasal hemianopsia, because what's being lost in this case is certainly nasal visual field information that's stimulating the left temporal retina. Then the information cannot reach primary visual cortex because of the lesion in the fibers on the outside of the left optic nerve. So that's basically a lesion strategy that occurs in front of the optic chiasm, whose deficits are monocular and ipsilateral. Causes of these lesions, we alluded to this earlier. Patients that develop optic neuritis, which is commonly seen in patients with central nervous system demyelinating diseases like multiple sclerosis, and patients that develop a central retinal artery occlusion. That's an anatomic end artery that, when occlusion, would basically disrupt the entire retina on a corresponding side. Both of those would cause basically an anopsia on the corresponding side. But now, common cause for a nasal hemianopsia is a medially directed internal carotid artery aneurysm that compresses just the fibers on the outside of the optic nerve just in front of and adjacent to the optic chiasm. So that's a very common cause of a patient's ipsilateral nasal hemianopsia. All right, lesion strategy number 2. This is probably the one that everyone remembers because it's so common, because it's got so many causes. And that is, what's going to be characteristic of a lesion that occurs at the level of the crossing fibers of the optic chiasm, as indicated by number 3? Well, in contrast to lesions in front of the chiasm, these deficits are going to be binocular, in that we're going to see shading in both circles indicating a deficit in a visual field on the right side and the left side respectively. In addition, lesions that occur at the chiasm are not only binocular, they're binocular in the sense that the visual field losses are restricted to being bitemporal losses, where you only get visual field shading losses on the outside of each circle, as indicated by number 3. And lastly, lesions that occur at the chiasm are heteronymous, which means the shading deficits are on different sides of the corresponding circles. In this case, you can see that there is a shading loss on the left side of the circle on the left, but on the right side of the circle on the right, a heteronymous defect. So classically, if the chiasm lesion is complete, the visual field deficit that occurs is known as a bitemporal heteronymous hemianopsia or hemianopia, as you can see there, assuming the lesion is complete. So now, what are the causes of lesions that compress the optic chiasm? Well, fundamentally, the common causes are due to compression by different forms of pituitary tumors. Because since the optic chiasm is in the midline, it's situated directly above and just anterior to where the pituitary gland sits. So now, but remember the distinction. There are two different forms of pituitary gland tumors that compress different sides of the optic chiasm, and at least in their initial stages only cause quadrantenopsias rather than hemianopsias. So here's the distinction. A pituitary adenoma commonly compresses the optic chiasm from below, inferiorly. And basically it is compressing the optic nerve fibers that are crossing in the inferior aspect of the chiasm that came from the lower quadrants of a corresponding nasal retina. But remember that because of the inversion and reversal of visual field information, lower quadrant information coming from the retina actually represents superior quadrant information. So what in essence happens when you compress the bottom of the chiasm and affect information coming out of the lower quadrants of each retina, the patient will have a bitemporal superior quadrantenopsia initially. Obviously, in later stages, a complete or large pituitary adenoma may compress all of the optic chiasm fibers and result in a bitemporal hemianopsia. In contrast, a craniopharyngioma, remember that it represents a remnant of the Rathke's pouch from embryology. A craniopharyngioma, when present, typically in younger adults, will compress the optic chiasm from above, and in doing so, compresses the optic nerve fibers from the superior nasal quadrants of each retina. But recognize, again, because of the reversal and inversion of the visual images, the information that's affected, or the visual fields that are affected, are the inferior temporal quadrants. So a patient with a craniopharyngioma that compresses the chiasm from above will initially have a bitemporal inferior quadrantenopsia. Note also that a large aneurysm at the juncture between an anterior cerebral and an anterior communicating artery may also initially cause a bitemporal inferior quadrantenopsia because of compression of the optic chiasm from above. So now, let's look at the visual radiations first in terms of how they're organized before we look at a diagram. Once we reach the area of the optic tract and the lateral geniculate body, we're going to be associated with lesions that are described as being past the optic chiasm. So before we characterize them, what we need to be specific about is what's different about the different elements of the visual radiations. First off, you can kind of subdivide them into two groups because a portion of them, those visual radiations that represent information coming from the upper visual field quadrants, loop through the temporal lobe in the form of Meyer's loop, before then projecting back to the parietal lobe to synapse in a very specific part of primary visual cortex called the lingual gyrus. The lingual gyrus is the part of primary visual cortex that is inferior to the calcarine sulcus. In contrast, the visual information from either the upper quadrants of the retina, but more importantly the lower contralateral quadrants of visual space, projects more medially in the non-Meyer's loop fibers, coursing only through the temporal lobe and not coursing only through the parietal lobe, and synapse in the area primary visual cortex situated superior to the calcarine sulcus, known as the cuneus gyrus. So let's look at this diagrammatically, first by making a generalization before we get specific about visual radiation lesions, and this is the point. All lesions past the chiasm are going to be again different than lesions in front of the chiasm or at the chiasm. Here again, like chiasm lesions, the deficits are going to be binocular. They're going to be shading losses in both circles. But now, very different. Lesions past the chiasm, all of them are contralateral in presentation, and they are homonymous. So what does this mean? It means if I lesion a structure, and in our example here at 4, 5, 6, and 7, if I lesion a visual structure on the left side at 4, 5, 6, or 7, the shading loss, the shading indicating a visual field loss, is going to be on the right half of a corresponding circle. And obviously the shading, depending on the extent of the lesion, will be on the right half or right quadrant of both circles, indicating a homonymous deficit, same side, the right half. As you look at the lesion that's illustrated at number 4, you can see that in this case, the shading indicating a visual field loss is on the right half of the left circle and the right half of the right circle, indicating a homonymous hemianopsia in this case. And obviously note that this is contralateral because we've indicated that the lesions at 4, 5, 6, and 7 are all on visual structures on the left side of this visual processing pathway, but in all of them at 4, 5, 6, and 7, you can see that all of the defects result in, or all of the lesions result in visual field deficits that are on the right side of the corresponding pair of circles. So finally, as we'll see, when we get inside primary visual cortex, where the lesion does not include any fibers leading to the cortex, patients will have a contralateral homonymous hemianopsia, but it will be seen with macular sparing. So let's be a little more specific. Certainly note at number 4, if the lesion is complete and involves, in our example, the left optic tract, that the patient will have a deficit that is contralateral and homonymous and expressed as a right homonymous hemianopsia in number 4. But now, because of the slightly different course taken by the visual radiation fibers, note the different lesion presentation that occurs at 5 or number 6. 5 indicates the location of the fibers in Meyer's loop that come out of the lateral aspect of the lateral geniculate body. They form Meyer's loop because they loop anteriorly into the temporal lobe before making a hairpin turn to come back and synapse in the lingual gyrus. An isolated lesion of Meyer's loop would result, in this case the lesions on the left, in a right homonymous superior quadrantenopsia, as indicated by the lesion as illustrated at number 5. In contrast, if the lesion include the non-Meyer's loop fibers that project directly through the parietal lobe into the cuneus gyrus, a lesion at number 6, which is on the left side, would result in a right homonymous inferior quadrantenopsia. And finally, as we've indicated, a lesion of primary visual cortex, assuming it's in its entirety, involving probably a vascular insult to the left posterior cerebral artery, would cause a right homonymous hemianopsia, but unique to intracortical lesions is macular sparing. So, in summary, obviously, most of the lesions past the chiasm result from vascular insults. Basically, lesions to the optic tract and or the proximal parts of the visual radiations comprising Meyer's loop, middle cerebral artery. Typically, the more posterior aspects, and particularly the non-Meyer's loop fibers at number 6, are probably irrigated more effectively by posterior cerebral artery, and certainly primary visual cortex at number 7 is irrigated by posterior cerebral artery. But recognize intracortex lesions only, as we indicate here, are going to be seen with macular sparing due to a collateral blood supply available to primary visual cortex from the middle cerebral artery. So now, finally, a summary slide that's illustrated here. And basically, you can see on the ventral surface of this brain picture various structures labeled there. And among the ones that are pertinent to visual field information are A, B, and C. A is the optic nerve, B, the optic chiasm, C, the optic tract. So the exam could show you a diagram like this and describe a patient that, let's say, has a homonymous hemianopsia and basically ask you where the lesion is. Well, as we know, homonymous hemianopsias occur only in a lesion that's past the optic chiasm, so the best answer looking at this figure would be C. And certainly if the patient developed a pituitary tumor that compressed the area at B, the bottom of the optic chiasm, like a pituitary adenoma, note that the area at H represents the area where the infundibulum was cut away from the pituitary gland. Note its proximity. So patients that develop a pituitary adenoma that just compresses the bottom of the optic chiasm at letter B would basically result in a contralateral superior quadrantenopsia. That would be bitemporal. And certainly a lesion at A that might result from optic neuritis will simply, if it's complete enough, will be an anopsia of a corresponding eye, a monocular deficit. So now other structures in this slide certainly include the tuberal region of the hypothalamus projecting down to the infundibulum at H. D are the mammillary bodies that we'll talk about in the limbic system. And the letters E, F, and G represent the oculomotor nerve at E, the trochlear nerve at F, and the trigeminal nerve at letter G. So what we've done during this part of the review is summarize the different kinds of visual field deficits and assign basically different characteristics of the visual field deficit when the lesion is either in front of the chiasm, at the crossing fibers of the chiasm, in fibers past the chiasm, or at the level of primary visual cortex. Let's now focus our neuroscience review on functional and clinical aspects of the diencephalon. As we've alluded to in other areas of our neuroscience review, the diencephalon has neural components, neurons, that are functionally linked to many other of the sensory, motor, and visceral systems of the body. So now first let's kind of localize where the diencephalon is. We know it fundamentally is situated just beneath the areas of each hemisphere, and it's bounded between its diencephalic components by the third ventricle. So what's shown here in letters A, B, C, and D are the approximate locations of the four components of the diencephalon. Letter A, which is the largest component of the diencephalon, is the thalamus. B indicates the location of the hypothalamus. C is the location of the epithalamus, which largely includes the pineal gland. D is the approximate location of the subthalamus, which we'll see is basically a basal ganglia structure. Note that